are in listen-only mode.
Good morning. I want to welcome you to Friday Morning Conference. We have a special treat this morning. Dr. John Miller, who is the Medical Director of the Partnership Health Center, is going to talk about healthcare for the homeless. This is a topic of interest to me because when I started more years ago than you want to know, we had free clinics and we were stealing drugs out of doctors' offices, and things have changed, but not that much, and John's going to tell you about that. He is Associate Director of Clinical Operations for the residency program. He's a member and past chair of the Global Public Health External Advisory Council at the University of Montana. He speaks on global health issues, Indian Health Service, traffic safety, food insecurity, homelessness. And he worked with the Indian Health Service in Zuni, New Mexico for 10 years. John?
Great, thank you very much. Thanks for that introduction. Can everybody hear me okay? Okay, great. Sometimes it's hard from up here to be able to tell what people are hearing. So thanks for that introduction. Here's kind of my introduction slide. We're going to go a little bit in a bit of a different direction than sometimes we go in Friday Morning Conference. I think often we spend a fair amount of time up in here at Friday Medical Conference talking about different medications, treatment algorithms, healthy lifestyle education, this kind of thing. But I think it's important to remember that the base of a lot of people's health status is in the socioeconomic factors, really basic things like housing, food, safety, this sort of thing. Then we've made a lot of improvements to health over the last 100 years, kind of in this second part of the pyramid around fluoridation or sanitation, some of the environmental changes that expose people to healthier things and decrease exposures to less healthy things. And then, of course, immunizations here in the middle have had a really large impact too. So we're going to spend most of our time down here touching on some of these things because at least I'm a medical doctor, and I did want to touch on some of that today. So first of all, I'll tell you where I'm coming from. I work at Partnership Health Center, and we provide access to affordable health care for people who need it in this county and from a lot of surrounding counties. So we see patients from as far away as Knoxon, Big Fork, Darby, Anaconda. Sometimes people come from Butte. There are some points of access in some of those areas, but a lot of people travel a good distance to get to us. One of the key things is we try to partner with community resources to help our patients in the ways that we can. And one of those things is to work at the Poverello Health Center. So we have a 2-room clinic. We staff it with a PA 4 days a week. I've actually never seen a patient in Poverello. I've seen a lot of homeless patients, though, as I'm going to talk to you about. We see homeless patients in our population at Partnership, and I suspect a lot of you who are clinicians see them in your clinic as well. I also helped start the residency program in family medicine here that we're about to graduate our first class, and that's a lot of excitement. I see Larry White there, who's instrumental in getting this going. So yeah, our mission here is to train people for rural underserved areas. Poverty, homelessness are major issues in rural areas. I think to a certain extent we think about it through the lens of Missoula and the Poverello Center, but it's an issue around the state. And so I think getting exposure to the residents on this is an important thing. And then this is my favorite picture from a Missoulian article. I'm sorry, I put it everywhere. But anyway, I think the other thing is that, we're trying to build teamwork concepts, interprofessional education. I'm happy to see people from other disciplines here today where we're going to talk about some of these issues and how we can work together to do as well as we can to help folks who are really at the highest need. So I don't really want to start by having us look at some of our preconceived notions about homelessness. I'm as guilty as probably anyone here in some of these things. This is from an LA Times article just a few months ago. But I think it's important for us to think about some of the ideas that come into our head when we see someone on the street or when we see someone in the clinic. Maybe they're not homeless, but they have a very chaotic social situation that's really affecting their health. I think sometimes we have to get past some of our ideas about them and that maybe they're making choices to some of these situations. And it's true that there are some choices that they make that you wouldn't endorse those choices. But when we think about the ways that stress affect the brain and people don't make wise choices when they're under a lot of stress, really it gets back down to those socioeconomic factors that really dictate a lot of this and lead people to the challenges that they have often living in the street. The second thing, and this is kind of an issue with LA, but it's also an issue in Missoula also, where people choose to live on the street based on where service is or how the weather is and this kind of thing. But statistically, it's just not true. Homeless populations are less likely to relocate than the general population. So just in this room, I know several of you who've come across the country to be here in Missoula. We're more likely to transport ourselves than homeless people are, and that's important just statistically to be aware of. The other kind of preconceived notions are that homeless are mentally ill, and while it's true that probably a lot of them are, and definitely a higher rates of it in the homeless population, the general population, it's not even a majority among homeless population. A lot of it has to do just with resources and what's available. And then I think this last point is really important for us to keep in mind, that really it's super expensive for us to do it the way we're doing it. Yeah, it's expensive to solve this problem, and so we're doing a lot right now for resources in this area, but I think we could be doing more. And I think it's really expensive, the ways that we're kind of inadvertently trying to treat this problem. So I just wanted to start there and just say, I think we're all there to a certain extent, and I think we need to look through this lens as we look at this problem. I think everybody's seen this, probably something like this, kind of a pie chart that looks at the wealth distribution in the United States, and that relatively small group control most of the resources. And so really I'm going to be talking a lot about these folks and these folks. That's where most of the homeless come from, and the rates are really high, especially among working poor. That's important for us to talk about as we set the stage here. I think we all know about the pie chart, but actually if you ask people and try to get them to kind of build the pie chart, they can't do it. People don't know actually. So here's the actual distribution of wealth with this huge amount in the top 20%. Americans think, yeah, it's like that, but there's still a lot down on the other 80%. And but ideally they think it should be here. So I think if people put it together, it might be different for different people in their view. They might underestimate the amount that's controlled by the top 20%. So this is a map of the United States, obviously, with different counties looking at the percentage of people living in poverty. And so you can see Montana is a real checkerboard. It's interesting as we go through these, as we talk about rates of poverty, rates of child food insecurity, rates of homelessness. Montana is almost exactly at the U.S. average. And it's also like the U.S. in terms of having areas of having a lot of poverty, mostly on counties with Indian reservations, but also other counties that are a little bit better off. And so you don't think about Montana as being kind of indicative of the United States, but actually in these issues, it is the case. So we have a fair amount of poverty in Montana, and we'll talk more about that. We'll show it in different ways. Getting back to some of those preconceived notions, we sometimes think of poverty as people who are unable to find work or choose not to work. But in the United States, kind of down here on the far end, we'll see that compared to a lot of developed countries in the world, we're more likely to have people in poverty who are working. And that's kind of a key thing for us to keep in mind as we think about how we can help homeless patients and people with food insecurity. So here's another way to think about that, just for working families in poverty. So this is for working families just in general. About almost half of them are either at 100% or less than 200% federal poverty level. So pretty significant rates of poverty for people, and really I would expand the definition of poverty to be 200% federal poverty level, because the numbers, I mean, I think that's pretty accepted practice that people expand that definition because the numbers are so low. So we have a lot of people who are working in families who are living in poverty. I think it's also interesting to look at the different occupations that you can see. Here's a pie chart. This is out of U.S. Department of Labor statistics, just like different things over here. I don't know if people can see this at all, but you got a big green thing here, retail and trade, and you've got kind of a rosy red that is services. So I think we see that just in our interactions around town, where people are in jobs and they're working really hard, but they're not always making a living wage. So this is, I think we have probably all seen this before, the Maslow hierarchy of needs. The reason I put this up here is because I think it's really important, like us thinking about how socioeconomic factors affect health, to think about how people operate and their challenges functioning in some of these higher realms if they can't meet their basic needs. If they don't have shelter, they don't have food, if they're under a lot of stress, if they fear for their safety. It's interesting, in some of the patients that we work with, a lot of them actually are performing in some of these areas. Some of them have very loving and supportive relationships, so it's not like if you do not pass go. If you're at this level, you can't go to some of the higher levels. But it does make sense that folks who have challenges meeting their physiological needs have also challenges meeting their other needs, particularly as it pertains to health. So this is just a statistic to say of those people, who are less than 200% federal poverty level, the rates of food insecurity and housing instability are really high. In Montana, the rates of homelessness by kind of a strict HUD definition would be somewhere in the like 10 to 13%. But there's a lot of people who have housing instability that creates a lot of stress for them, that definitely has major impacts on their health. And so that's just something to keep in mind, is that this is actually a pretty common issue. This slide looks at kind of changes in homelessness by state. I'm going to talk a little bit about some national or federal initiatives to try to decrease or end homelessness over the next 10 years, and that started in 2010. And I think that this shows some of this starting to happen here, where overall in the United States homelessness decreased actually somewhat dramatically from 2010 to 2015. I think it decreased about 3% overall. And they made a lot of gains in veterans homelessness, helping people who have been in detention or in the incarcerated to get back to a stable housing situation. So there's been some targeted places that it's gone well, but I don't think we've enjoyed some of the same benefits in Montana. And to talk a little bit about that, I think we've seen it a little bit in Missoula here, but I think it's also important to think about the state as a whole, and it's particularly around rural health. And it's dying down a little bit over in the Bakken right now, but in this 2000-2015 period, I saw a lot of patients who were kind of commuting between here and the Bakken, had a family here, knew it wasn't going to be long-term over there, were living in very stressful, really substandard, still very expensive places in the Bakken. And so this is an issue that affects us here in Missoula, but it's also an issue in rural areas. Sometimes it's for people who are making actually a fair amount of money on the books, but still having challenges getting stable housing because of the situation in which they're working and the cost of housing in different markets. So I alluded to this earlier, and this is the levels of homelessness. So here's kind of maybe the way we think about homelessness up on the top. So people who are sleeping outside or people we see on the street, folks who are literally homeless. So folks who are out on the street plus those living in or staying at an emergency shelter. And here's the HUD definition. So these folks up here plus those sleeping in traditional housing for the homeless. And then here's the broadest definition. I think this is what we see a lot in our clinical situations is all of these people above plus folks who have a lot of insecurity. They're living doubled up or even more than doubled up. Just the other day I saw a patient, 42-year-old with seizure disorder and depression who I happened to ask her, how's your living situation? And she said, well, actually it's really horrible. I've been living with my mom. My sister moved in because she lost her job. I had a friend staying with me in my room, but my sister booted her out. So there's just a lot of stresses around that, and that's kind of ended up being the focus of the meeting because you got to take care of that before you can get to some of the other issues. And luckily at our clinic we have good resources to be able to help those folks in those situations. So housing instability, this is a definition that I found that I thought was helpful for us just to think about some of those patients that we're seeing who maybe we wouldn't think of them as homeless, but maybe it's important to ask them about their housing situation in order to understand their vulnerabilities and the risks. So difficulty paying rent, if they pay more than 50% of their income on housing, having frequent moves. One thing that came up in our needs assessment for the Lowell School, school-based health center, that's about 10 blocks from here. And I actually can't verify this, but it was an anecdote that I thought was very powerful, was that in a certain class, I think it was 25 students started the year and 25 students ended the year. This is like back in 2009 or something like that. But none of the 25 kids were the same. So it's pretty incredible. I think luckily the area in the Lowell School is changing, transforming, and I don't think that's as much of a problem now as it was when we were doing the needs assessment. But it's important to keep in mind that this is a big issue, frequent moves, housing instability here in Missoula. And then there's living in overcrowded conditions and doubling up, as we already talked about. So this is another way that I like this slide that I found on this website for the Affordable Housing Institute, where it talks about kind of how homelessness in America kind of fits together, where we think maybe of homelessness in this little circle up here in terms of those who are chronically homeless, but then there's a lot bigger group of people, many of whom get services at the POV and seek health care at the POV or at community health centers or in other people's other providers' clinics here. Then you have folks who experience homelessness maybe as a transition where they have some nights without housing. Then folks maybe who they actually have a stable roof over their head, but it's a worst case situation. It's kind of squalor, it's unsafe. They have to be careful where they step because there's a hole in the middle of the kitchen floor or something like that. And then folks who have put a lot of money of their earnings into their housing. So this is just kind of a way to think of the problem in a bigger way, maybe in the ways that it reaches more of our patients so we can be more sensitive to this for our patients. So getting back to HUD definitions, so this is from a HUD slide that kind of came through fuzzy, but they look at it in a lot of different ways. It's actually a really cool article. It's a report to Congress in 2014 on progress since 2010 on their efforts to decrease homelessness. And this looks at total individuals and then total people in families. So here you can see that more than a third of people who meet the HUD definition of homelessness are people in families. Okay, so kids and their parents typically is kind of the way to think about that. Most of the people in families are in sheltered situations and less are in sheltered situations. And among individuals who are not in families, it's much more common for them to be unsheltered. Here's another way to look at it in terms of the percent of all homeless within each age category. So among all homeless people who meet the HUD definition, you still have almost a quarter who are under 18. So that's pretty significant for those of us who care for kids in our clinic. Being sure that we know about that family's housing situation has a major impact on their health. It's something that we need to be aware of. Then you have people who are transitioning from home to independence, many of whom struggle with that, and there's challenges certainly financially in that time. And then, of course, the supermajority of people are over 25 and older. So moving on from the statistics to some of the health factors and things for us to keep in mind. I mean, how does homelessness affect health? Here's a few things that are out of a great kind of review article out of the American Family Physician that I'd encourage people to look at if you have an interest in kind of putting all this together. I'm going to allude to some of the issues that are in this, review article, but I would encourage you all still look it up out of 2014. So poor nutrition, overcrowding, sleep deprivation, the stress response to that and the different hormones we have in our body that affect our metabolism and our psychological health. It's pretty significant if people don't sleep well, the challenges they have. Fear of violence, the violence that they're exposed to, sexual abuse, physical, emotional trauma, you know, just folks are exposed to a lot of different things in a homeless situation that can really affect their health in an important way. And as a result, homeless people die at a really high rate, especially high rates for the ages that they are. So this is a really powerful graph, I think, that shows that, you know, just this is actually of all homeless people, what percent are in what age groups that die, of those who die, what percent are in what age groups. And you just see that there's a big burden in these younger because of violence, suicide, and also medical problems that lead to death. And that has a big effect on their life expectancy. As you know, loss of life early on in years really affects life expectancy longer. And so another way to think about this is, you know, this is by, this is out of British Medical Journal looking at homeless compared to different racial and ethnic groups. But another way to think about this, if you just block this part out, blocked out the labels, you could think of maybe you'd have some developing countries and maybe a lesser developed country or a developing nation where if you have a lot of young people who are dying, it really affects life expectancy in a really significant way. So looking at some of the ways that this happens, and I just wanted to look at some of the examples. So cardiovascular diseases, hypertension, diabetes, even leading into heart disease and such is, you know, some of the things that lead to the problems that make these things more likely among these populations. So poor diet, stressors, compliance, just the challenges of taking some of the medications that have been shown to be advantageous and decrease risk of advancement of disease. So it makes it really hard to control some of these diseases. So here's just kind of an example of a typical patient population in a clinic where most of your patients have pretty good control, some are less. I think it's much more common to have, you know, folks over in this area are just folks who have horribly uncontrolled diabetes. It's just out of control. And I think if we have a patient like that, it's important to think about some of the underlying factors and not focus so much on the medications myself to try to understand why they're out over in this range rather than in this range. It's usually not about medications in that realm, but that's just my particular view. And I think the guidelines support it. So looking specifically, this is out of the Canadian Medical Journal, looking specifically about diabetes in the homeless population, is that, you know, just the vast majority of homeless people with diabetes, so this is folks who would be on medications or not on medications, 72% of them report difficulty controlling their diabetes. So that's almost everybody who would need medications has problems, has difficulties, and the reasons kind of outlined here. Limited control of diet is really important. Challenges keeping medications secure and stored properly, refrigerated. Some things need refrigerated so they lose their bioactivity. I had a patient down when I worked down in Zuni. He was actually Navajo. He would travel about 20 miles on dirt roads to get to our clinic, and he was way out over on that other end. He had hemoglobin A1C at 12 or something like that, and he was taking his insulin. I mean, I was believing all of this, and it's like, what is the problem? And the problem was he wasn't storing it with refrigeration because he didn't have electricity, and so we were able to get him a way to keep it secure. And he came back and his hemoglobin A1C went down to like 7. You know, it was very impressive. He knew how to take care of his diabetes. It was a simple fix around really a substandard home housing situation that made it more difficult. So I think it's indicative of what we're talking about there. And then side effects of medications. So we might prescribe medications that in some other populations could be really helpful, but in these folks it's just not practical for them to take it. So it's really important for us to think about that. And we'll talk more about some of the cautions around medications later on in this talk. So this is just kind of a picture of, you know, the burden of homelessness and mental health. You know, I think it's important to think about the fact that folks with mental health are more likely to be homeless. That makes intuitive sense, but it's also important to recognize that the homelessness and the stresses around that make it that it's harder to control their mental health, and they're more likely to be out of control in that way. So it's important for us to look at our system and how we've dealt with mentally ill people over the last 40 years, and not to endorse how it was back in 1963, but we've really transitioned from a time of a concerted effort to try to take care of people with mental illness to a place where those services are a lot less available. And that's led to a big increase in incarceration and homelessness as a result. So in terms of looking at dual diagnosis, you know, definitely a higher percentage of people with dual diagnosis are on the streets. And here's just some statistics about it from a couple of different sources. So that review article basically kind of just pointed out that 20-30% of homeless have mental health problems, 30 to 50% have substance abuse. I found another source that broke it down to say that you know, the rates of alcohol abuse are more than a third. Regular drug abuse is only about a quarter, much more common, but maybe not with what some of our preconceived notions would be. Another thing about how this breaks down that I think is really important to discuss is that alcohol abuse is much more common among older people who are homeless, and regular drug use is much more common among the younger people who are among the homeless population. So the suicide risk, is important for us to have this on our mind, certainly whenever we work with folks who have mental illness. And this is just for some red flags. These are some areas to keep in mind where folks are at higher suicide risk, younger, lower educational level, as well as folks who have been on the street longer, started to lose hope that things are going to turn around in a better direction. I also wanted to spend a couple of slides talking about children in the homeless population. This picture actually inaccurately points out that 1 in 3 homeless people are under the age of 18. It's actually 1 in 4. It's not 1 in 3, but it's still a pretty significant issue among the kids that we see, especially in a community health setting. So this slide I like just because it kind of put it all together in terms of how poverty and poor housing affect child health. So, you know, rundown housing puts them at risk for social isolation. That's a huge issue in terms of how people learn skills, develop coping mechanisms to be able to interact with others in constructive and positive ways without violence, for example. And then just exposures to different pathogens are higher in people who live in substandard housing. Then risk for lead poisoning, some of these things, how it causes learning disabilities, brain formation. Kids who are homeless are much more likely to get sick and more often than kids who are in a more stable situation. Some of that's overcrowding and just increased exposure to the different pathogens, but also that their immune system, because of the stress they're under, the poor nutrition, increases their risk of getting sick. So it leads to just some pretty impressive statistics about kids who are just more likely to get sick because they're homeless. And I would extend this definition to not just people who meet that HUD definition, but also a lot of the people we see around folks who have home instability, housing instability. So this is kind of a red flag if you're seeing a lot of kids, or the same kid multiple times, or kids in a family multiple times who have a lot of the they're sick a lot of times and their parents are bringing them in. If you're not sure about their housing situation, it's important to touch base about them on those things, because there's some good social services we can connect them to provide them with better care and help them overall. So here's some links. I'm not going to go on these links. I toyed with the idea of going on these links. If we did, this adapted clinical guidelines under the Health Care for the Homeless page is really cool. It's a page where it has like general guidelines where you can't put them on a slide. There's a bunch of different things to keep in mind in working with homeless patients. And then it breaks it down by different disease states. So diabetes, hypertension, the different things to keep in mind under each of those different problems. And then it also has a link to this summary that's an American Family Physician that I would encourage you all to read, because it's a really interesting resource. This sums it up, though. This is really what it's about in terms of helping to decrease the health burden and decrease costs for folks who are homeless with health problems. The big issue is recognition of the problem. So trying to make sure that for all of your patients, what's their housing situation, is it secure, kind of moving on from there, I think is really important. For those who do have housing instability or are homeless, the fact that we do have reasonably good access to care in this community, I think is good, and I think the residency program is a big part of that, because we've been able to expand our provider base so dramatically by bringing the faculty and residents in-house at Partnership Health Center. There's a lot of services to try to transition people to stable housing. That was a big change in 2010, to try to transition from emergency and just kind of transitional shelters into permanent stable housing. So this is kind of a key thing for people's health to get better and to decrease the health costs. We need to get them into stable housing. There's good evidence to show that it does do those things if we're able to do it. And then supportive services, ways to help support all the other things that people need around food or the different services they need, and ultimately get them into a place of employment, plus supported services will also feed back into the system to allow people to be even more stable in their housing and continue to have good access to care as costs come up around those things. I guess this is one place to mention that we have a Health Care for the Homeless grant at the Poverello Center, so people are able to access care for free. There's no cost obstacle for them to access care there. And they also have their medications covered by that grant, which makes a big difference. For the homeless people that we see at Partnership Health Center over at the Creamery, they kind of face a lot of the same burdens and obstacles around getting care in terms of having a nominal fee. I think it's $15 right now that everybody needs to pay to get care. There is a sliding scale that we have that they probably wouldn't have to pay more than $15, but if other services came up, they would have to accrue those costs, such as medications or labs or these kinds of things. So it's always just important for us to keep in mind, whether we work at Partnership Health Center or elsewhere, how is my ordering of this lab or medication going to impact them financially? Because I think it has a big impact on whether they're actually going to do the things that we think could help them and whether we're putting our efforts in the right place. Just want to touch on a couple of things that you could find on that page under the certain issues, but I thought this was an important thing for us to just to think about is that the guidelines for the general population around prevention still apply. It's often lacking in the homeless population because a lot of people don't have stable primary care, and it's more they come as things become more severe, and often those visits are really challenging because you're dealing with a lot of major issues, and preventive health can be further down the line. But that's where if you can stabilize the situation and give them good access, you can get to some of these other things, especially the annual flu shot. I remember when I was a resident, I did a ortho rotation at a big hospital, Harborview Hospital in Seattle, and I was really impressed by this one orthopedic surgeon who was kind of pimping the residents who were there, and saying he was pointing out that this homeless person was basically immune deficient. You know, it wasn't really what I expected from an orthopedic surgeon. It's like, why is this person back, or why is he still sick, or, you know, it's because he's homeless. He doesn't have good immunity to the different problems. I think he had a post-op infection or something like that. But it was a good recognition on his part, and it impressed me that was the case. I don't know why I went there. That was total digression. Oh yeah, that's where it was with the annual flu shot. There's my anchor. I'm back. Thank you. Here we go. Exposure-related conditions are important for us to keep in mind. I think we typically think about this, but the rates of hospitalization in the homeless, ER visits also, so ER visits and hospitalization are much higher due to exposure-related conditions than in the general population. And that makes sense because they're exposed to more. The absolute temperatures that they face are really important for us to keep in mind. The duration of exposure, kind of those two multiplied by each other gives you some weighted score to tell you, boy, this person could really be in trouble around an exposure-related condition. But, you know, there's different things that increase people's susceptibility to these things, so the different substances that maybe alter blood flow, vasoconstriction, some of these things, the poor nutritional status and underlying disease burden that they bring to this. I think particularly in rural areas, this can be an issue where folks maybe have to travel to find alcohol, and they need to get back to home, and they can get exposed to cold, and people pass away that way. I think that's something that folks deal with in the emergency room and in hospitals every day in our state. So talk a little bit about strategies to end homelessness, and this is really kind of, I think, at the base of improving health status for our homeless population is to get to some of this. So in 2010, Congress passed and President Obama signed a bill to create the strategic plan to prevent and end homelessness. And here were the goals of this Opening Doors initiative, and we're already too late on one of these, you know, prevent and end homelessness among veterans in 2015. We've actually made a lot of progress on this, but I mean, this is really, it was unattainable when they wrote it down, but I think it was a goal in terms of setting, you know, let's prioritize in this group to give them the resources to transition back to, as veterans, back to society. Finished job of ending chronic homelessness in 2017, so that's some of the, if you look in your mind at somebody who's homeless, they're probably chronic homeless, and trying to decrease and end that in 2017. This HUD paper, this HUD report has really good data that we are making good progress in decreasing rates of homelessness among veterans and among the chronic homelessness within this time frame. So I think that's encouraging. We've also decreased this rates of homelessness in families, and I think the main issue with this is that some people might still meet the HUD definition, but we've transitioned more toward permanent stable housing, which I'll show you in a second, that I think makes this kind of a more stable situation for folks who are in this category. And then setting a path. What is our path to ending all types of homelessness? I think that'll be a different talk where we get into all that. So what it's created is this kind of a new way of thinking of transitioning people to more stable housing. I think there used to be a lot of emphasis on emergency shelters, transitional housing, And now it's kind of more wrapped around sort of support for folks who are homeless under this label, rapid rehousing is the idea. So trying to identify where are the places in the community where people could live, where maybe the rent is affordable, what parts of town where people can live, rent and move-in assistance for folks who need it. That's the difference to get them into a stable housing situation. That assistance for working poor is a really important service that we can provide as a society in helping people. Then this idea of case management and services, and we do a lot of this at the POV, where we actually have a social worker, a full-time social worker at the POV alongside the providers working, and it really makes sense because this is kind of the crux of trying to improve people's health status. So intervene to prevent the loss of housing for people who are in an unstable situation. That's not so much what we work on, but there's a lot of good resources in the county for that. And this is kind of the key thing, is immediate action when homelessness does occur. So shelter and support services, and then trying to secure this permanent stable housing. So here, this shows the transition from like 2010 to 2013, and it's gone broader. And PSH here is permanent stable housing. So trying to increase the amount in permanent stable housing and decrease the amount in emergency shelters and temporary transitional housing. So I think this is really important. Medication cautions. I have 2 slides on this. I'd refer you to the articles. It has a lot of good specific things about different medications to keep in mind. But really, when I think about some of our patients that we work with, almost every medication we prescribe, we need to think about what the costs are, both in terms of financial costs and the risk to the patient, and side effects, potential adverse reactions versus the benefits they're going to get from those medications. And it's just that issue is accentuated in people who are homeless or have housing instability. And these are some of the ways. I mean, the cost to the patients can be very significant. So like diabetic test strips, I mean, that's always an issue with almost every one of my patients who's trying to monitor their blood sugars. It's just super expensive for them to keep a close track on their diabetes. So I'll often march out, kind of draw something out where I say, okay, well, check it like almost every morning, but then kind of vary when you check it at other times of the day. So maybe morning and lunch, then you can skip a day, morning and dinner, and then morning and bedtime, and then bring those in. And I've gotten that picture of the whole day, but it's not all in one day that you get it. It's over a week. Maybe you get 12 numbers, and you can try to manage that scarce resource for them in a way that gets you the information to be able to adjust their medications. You know, I talked about refrigeration being kind of a big issue with insulin, but safety is a huge issue. And, you know, controlled substances are an issue even for people who have very stable housing, but they're even worse for somebody who does not have stable housing. So it's just a huge kind of red flag for us to have in our minds. Then the abuse potential, so there's a number of things that people use or abuse to get highs, different medications that can accentuate and prolong highs. I wasn't sure what to call this. Downers, it's probably not right. It's kind of, it dates me or something like that. But, you know, the different things that don't really give you a high, but people abuse pretty significantly. So just important for us to keep in mind the cost, storage, and abuse potential of the different medications. And then really to think about the side effects and the high risk of adverse reactions. So the sedation side effects, folks who need to be able to stay up and they need to leave the shelter to be functional during the day, or they're just starting a job and you don't want them dealing with a lot of side effects where they're groggy or something like that. Frequent urination for somebody who can't find a bathroom is really problematic, you know, so these kinds of things. And then I think there's higher risk rates of adverse reactions for some of the medications because of the instability, that medications can be lost or stolen, or they're relatively malnourished or don't have good access to food and water, or they have liver disease, some of these things. So that's what I had for homelessness. I'm going to take about 5 minutes now to talk about food insecurity because it's something that we've been working on at the clinic, and I want to share what we've done. And I think it fits well with homelessness for us to think about how we can help our patients do better. So this is kind of a slide like the one I showed before, where map of the United States, rates of food insecurity are kind of checkered throughout the state. Some counties are higher, some are lower. Just like in the United States, you have the Tex-Mex border, you have the Deep South, you have Appalachia, you have the Indian reservations. We can put up 100 slides like this and they'll have pretty much the same pattern, and we see the variation in pattern in the here in Montana. The rate nationally is about 22%, and that's the rate in Montana, is 22% of food insecurity in children. So talking about food insecurity for all ages, the rates are 16.4%, but as I mentioned, in children, they're higher risk, and their rate is a little bit higher at 22%. Elders are also at higher risk, as you can imagine. So the Food Assistance Program, just some data from the Montana Food Network, 1 in 4 Montanans are eligible. Children in food insecure homes, almost all of them are eligible, and we just need to kind of help connect them to resources. But with that, with participation is very low. A lot of people don't take advantage and get the support from the resources that are available to them. So when we look at percent on SNAP benefits, it's a lot like that previous map. This is actually not out of National Geographic. They always put kind of more information on their map, so I found this and wanted to put it in. It actually points out some of the big counties down in South Dakota where it's almost all native populations and the really high rates. Also in New York and the Bronx, down in the Texas area, 15% here on SNAP benefits. Montana is the checkerboard that we might expect. This gets us to the idea of food deserts, and where people live can be actually pretty remote from like a major supermarket. They may have access to like a Speedy Mart kind of thing, but it's kind of a long way to a grocery store on the Northern Cheyenne Reservation, for example, or in the Navajo Reservation here. There's also in Chicago, there's areas where you're like somewhere in Chicago, relatively close to downtown, and it's a mile to the closest grocery store. That's urban issues, but it's interesting to think of food deserts and the difficulty getting food that some people have, particularly affordable and healthy food. So what are we going to do about this? This is the Screen and Intervene that was brought to us by the Missoula Food Bank. Very interesting. They came to us, me and Narissa. I think Mary Jane Nealon was on it as well from the very beginning. We brought her in. They're suggesting that we do this screening tool, and we do a lot of screening tools at Partnership, so I was resistant to the idea of adding one more screening tool that we give to everybody. But these are important things. The first question really gets at worry about whether food will run out, and then number 2 is whether it actually didn't last, the food. So we were thinking about how to pilot this is basically what we did. And so we decided to pilot in our prenatal intakes because we've got really good support around those patients. And I've got just the initial information from about a month of new intakes. And it's pretty impressive. 43% of the people of pregnant patients had food insecurity. And then elderly with a BMI of 22, I didn't set this BMI. I wouldn't have. I would have set it at 19 and tried to get the underweight elderly or overweight elderly. So this is kind of a mix of high risk and lower risk population. But even with this, so we did our 3 satellites, the Creamery over in Superior and up in Sealy, kind of 42% had food insecurity. So pretty important. Impressive and kind of a mixed population. not just the people who are showing us signs that they could be malnourished. What's interesting is like people know about Meals on Wheels, but most of them never get food or services from Meals on Wheels or go to the food bank. So the intervene part is for us to be aware of the different types of services that can be available. So food stamps or SNAP, supplemental nutritional assistance program. The food banks, there's actually, I think there's at least 4 in town. There's the Missoula Food Bank plus different denominational and non-denominational food shelters, and then Meals on Wheels. So there's good resources for us to connect our patients to for those who need it. And then, of course, for our pregnant patients, getting them connected with WIC. That's been a real priority at our clinic, and I think we've done really well around that and getting them access to care in the first trimester. So that brings us near the end here. So the things that I've talked about in the last 50 minutes or so are really just try to get us to think about our patients, think about their housing situation, recognize that patients, that we have patients who are homeless and who have housing insecurity in a way that really affects their health, and for us to try to probe into that. Then to utilize homeless patient care guidelines, and that's really to be super careful with medications and err on the side of not prescribing versus the side of prescribing, like I think is sometimes our default in medicine otherwise. And then also trying to identify patients with food insecurity and trying to connect people with the appropriate social services so that we can help them, so we can help them do better also with their health statuses as well as their social circumstances. So with that, I'd open to any comments, questions that folks might have. And George has a mic there, so that's good.
John, you're providing a lot of services at Partnership. Many of them are non-reimbursable. What is the funding pattern for Partnership or for any community health center?
Yeah, so we have a lot of federal grants, mostly federal grants to support our services. And there's huge compliance and reporting requirements around that. I think it's led us to do some very cool things around quality, knowing how we're doing in terms of performance on some of the measures like percentage of diabetics with a certain hemoglobin A1C or that sort of thing. But there's a lot for us to track and make sure we follow the rules and stay within the lines. But most of it is the federal funding. And then we also have a pretty significant contribution from patients because we're pretty consistent about getting the nominal fee from people. People can be seen without having the nominal fee, but we don't want that to be kind of the default. We want the default to be that people would pay their nominal fee. So people are contributing as they go. Yeah, and
this is along the same lines. What percent of your folks, like this last year, get 100% of the benefit? In other words, what percent are Medicaid, what percent are Medicare, what percent have no payer source whatsoever? Then my related question is, I know when you guys started, both hospitals were providing lab, x-ray, and other more expensive services, I believe, free of charge, or at least on a sliding scale, and is that still happening?
Yeah. So remind me if I missed one of those questions. So I always start with the last one first because that's the one that I just heard. But so when I first got here, we could just say that the person needed an x-ray at St. Pat's and St. Pat's would do the x-ray, and it was free of cost to the patient. And that ended probably 3 years ago. And so, St. Pat's, I think, has a fairly supportive charity care sort of thing. So I try to reassure patients that they'll likely get the support they need, or some of the support they need for an imaging study, for example. But it is more of a barrier now for our patients than it used to be. The hospitals do support Partnership with in different ways, not just by them having a presence on our board and helping to guide us, like David Lechner and Joyce Dombrowski are both on the PHC board and are very helpful, but there are some financial contributions from both hospitals. And then I think you were asking about payer mix. That's really transitioned over the last few years. So the residency program, like bringing in Ned Vasquez, Mark Mintel, and now Rob Stanger, so local providers who had kind of a different payer mix than the typical PHC payer mix. So back in 2011 when I came, it was like a super majority were self-pay, maybe 10% Medicaid, 10% Medicare, and almost no private insurance. Whereas now it's about 20% Medicaid, 20% Medicare, 20% private insurance, and then I guess that leaves you with 40% self-pay. So it's definitely transformed. It's changed. I think Medicaid, we've definitely seen a big thing with now this Help Medicaid. Medicaid expansion has helped a lot of our patients. And we do a lot with our eligibility technicians to get people connected to the kind of the best thing for them in terms of having health coverage.
Social workers are a real big part of your managing of these patients. What's the ratio that you have of providers to social workers? How many would a clinic have to employ of social workers per MD or mid-level?
Yeah. Good. So yeah, the case management that's provided by social workers and by our MAs, LPNs, and some RNs do some case management as well. So the support is we have a lot of support at Partnership, and I think it's a good benefit. It can be hard to figure a ratio. You have to be kind of a math genius to do it or something, because we have like now 40 plus, 45 different providers who see patients at Partnership, but they're all little pieces like FTEs. So I think we're at about 13, 14 FTEs, and we have at least that many support FTEs of people doing case management, maybe half of that. So we have a couple of social workers and then nurses who are doing specific case management under different grants that we've been able to. We're pretty aggressive at applying for grants, being opportunistic to say, okay, here's a funding opportunity to help us do case management of, you know, the highest risk Medicaid. Oh, we can get it for a larger group of Medicaid. Oh, we can get back to this smaller group of Medicaid with some additional funds. It's just like this ongoing conversation that is there to try to get support for the different patients at Partnership.
Have you noticed any appreciable impact on the Family Promise program in Missoula?
I think I've seen that. I think I've seen the benefit. I think there's a number of different services working toward helping people secure permanent, stable housing, and I think I've definitely seen some effect there. Some of the supportive housing around pregnancy we've seen a lot. So Mountain Home does some good work that we see. Carol Graham Home. I shouldn't get into mentioning because there's a lot of people doing good work. And so I didn't mean to leave anybody out. Those are just ones that jumped to my mind. So I think there is good support for people to try to, I think the key around it is to prevent homelessness. So people who are at risk, trying to get them resources, early intervention, and then stabilization and maintenance of their stable housing once they're there. So it's really a kind of a lot of services that are needed for people, but it makes a big impact on their lives, but also on the broader society and what we're spending on all of the different things that are related to that. Okay. Well, thanks a lot. I hope everybody has a good weekend.
Comprehensive presentation.